Hi guys, good evening all of you. So I will start with the UVEA quiz questions. So 10 questions. So we're going to start with the first question. Primary site of inflammation in anterior uveitis. I think this is new for a lot of you. See, the primary site of inflammation is the aqueous humor, which is anterior chamber. Okay. So yes, it looked very tempting to mark pars plicata, but the primary site of inflammation is a cavity. Okay. The cavity containing the aqueous. So among the options, cornea, pars plicata, iris and anterior chamber, the answer would be anterior chamber for this very reason. Okay. Similarly, when you talk about the primary site of inflammation in intermediate uveitis, it would be the vitreous. Yeah, not the pars plana. Okay. Or similarly, if they ask pars planitis, it's not the pars plana, but it would be the vitreous. Okay. Question number 2. Most common cause of acute anterior uveitis. Okay. Option A, idiopathic. Option B, tuberculosis. Option C, HLA-B27. Option C, Behçet's disease. Yes, all of them can cause anterior uveitis, although tuberculosis is not acute, it's more like a chronic. The most common cause, there is a close call between idiopathic and HLA-B27. The answer is HLA-B27. HLA-B27 is the most common cause of acute anterior uveitis. Is that clear? And those of you who joined in late, guys, anterior uveitis, the primary site of inflammation is a cavity, the aqueous. So amongst the options, anterior chamber was there. So anterior chamber containing the aqueous is the primary site of inflammation in anterior uveitis, not the iris, not the pars plicata. Although yes, iridocyclitis we say, and when I say iridocyclitis, it is iris and pars plicata inflammation, but primary site of inflammation is the aqueous. Okay, so in that case, it was anterior chamber. The next question is very straightforward, no two ways about it. Hemorrhagic uveitis is caused by, even if I don't give you an option, you should be able to say it is varicella zoster, that is VZV. That is the answer. Then filamentous keratic precipitates are seen in. See, filamentous keratic precipitates is another name for stellate keratic precipitates. If I'd asked you stellate keratic precipitates, I'm sure you would have answered this. So stellate keratic precipitates are seen in which condition? It's seen in Fuchs, no? Fuchs heterochromic iridocyclitis. So stellate keratic filamentous keratic precipitates are, that means so stellate keratic precipitates are non-granulomatous, so they are fine KPs. Okay, they belong to the non-granulomatous variety, because Fuchs is non-granulomatous. Is that clear? So filamentous or stellate KPs are fine granular KPs. Hi beta. Okay, you got it right. Okay. Now the next question is a previous year question actually. A young adult male presents with acute anterior uveitis and low back pain. Most likely causes. Sure. Okay. Hi Rekha. Good. Yeah. So this is a typical question. Again, your ankylosing spondylitis presents with a low backache, HLA-B27, young adult, anterior uveitis. Okay. So the answer is ankylosing spondylitis. Very good, Kaushik. Very good. Badhiya. Okay. Hyperchromia of iris is seen in all except. Now this was a little new for you probably. Nevus of Ota. See, nevus of Ota, you get blue sclera, and you can also get in the iris hyperchromia, darker colored iris in nevus of Ota. Okay. Siderosis bulbi, that is when you have iron toxicity, iron foreign body inside the eye. Yes, again you can have a darker colored iris. Congenital honor syndrome. No, congenital honor syndrome, you'll have a characteristic hypochromia. That is a differentiating feature between congenital and acquired honors. No. So it's not seen. So that is the answer here. What was the last option? Sturge-Weber syndrome. Yes. So Sturge-Weber syndrome, where you have this capillary hemangioma on one, the cavernous hemangioma on one side of the face. So that side you will have a darker colored iris. Yeah. So the question was, hyperchromia of iris is seen in all except congenital honors, where you will get hypochromia of iris. Is that clear? Okay. Next is very straightforward, bacha jaisa question. Headlight in fog appearance is seen in posterior uveitis caused by, the most common cause of posterior uveitis, toxoplasma. So in toxoplasma we get a headlight in fog appearance. Yes. So that's a very important question for FMGE bache. Yeah, very straightforward question, but a very, very high yield question. Next one, again straightforward, but again depends on whether you've read the topic or not. Sunset glow fundus. Sunset glow fundus is seen in Vogt Koyanagi-Harada syndrome, your favorite VKH. VKH syndrome, in the fundus you see a sunset glow appearance. Okay, sunset glow fundus. Okay, the next question is a little lengthier, but it's very easy. A 30-year-old patient presents with redness, photophobia, decreased vision in the right eye. And examination shows ciliary injection. When we say ciliary injection, it means your circumcorneal congestion. Okay, redness, hazy cornea, then irregular pupil. What is the most likely diagnosis? So this is a case of an acute red eye with sudden painful decrease in vision. This is one of the favorite topics of examiners. One or the other keeps coming in. Okay, so let's look at the options. Option A, conjunctivitis. See, conjunctivitis, I've told you, it doesn't cause per se decrease in vision. It doesn't cause photophobia. Yeah, per se. Very, very rare cases like epidemic keratoconjunctivitis. Otherwise, it doesn't. So very, very least likely. Let's see the others. Posterior uveitis. See, posterior uveitis will not cause redness. Okay, it will not cause pain. It's a painless decrease in vision. So it is ruled out. Next is acute. Okay, anterior uveitis. Maybe. What is option D? Acute congestive glaucoma. So I am left with only two options, C and D. Anterior uveitis and acute congestive glaucoma. Guys, acute congestive glaucoma, cornea can be hazy, yes. Sudden painful decrease in vision, redness, photophobia, all that is right. But characteristically, there will be a mid-dilated pupil, like the question you got in this INI-CT. Yeah. So a mid-dilated pupil is characteristic of acute congestive glaucoma. Yeah. And they would mention probably the intraocular pressure or even about shallow AC or something like that. Or even if not, mid-dilated pupil is a giveaway. But here, irregular pupil. Irregular pupil means festoon pupil. Okay, you got multiple posterior synechiae giving rise to the festoon pupil. So can I have hazy cornea? Yes, I can have raised IOP in anterior uveitis also, because all the inflammatory debris that is there in the aqueous going to go and block your trabecular meshwork. Definitely will cause some kind of secondary open angle glaucoma. Yeah. So because the raised IOP, the cornea will be hazy. Yeah. So the answer in this case is anterior uveitis. Okay, so patient presents with redness, photophobia, decreased vision in the right eye, examination showing ciliary injection, hazy cornea, irregular pupil. All right. So please keep in mind, irregular pupil is another name for festoon pupil. Mid-dilated pupil, they will not say irregular pupil. They will say mid-dilated. Okay, and it will be characteristically not reacting to light as well in acute congestive glaucoma. Although in your INI-CT this time you didn't get the word acute congestive glaucoma, because they use the current nomenclature, which is APAC, acute primary angle closure. Okay, so that is a current nomenclature for ACG. Okay, the next question. Oh, we've come to the last question. In a severely traumatized eye, enucleation needs to be done within dash, that is the period of injury, to prevent sympathetic ophthalmia. So what is a golden window to prevent sympathetic ophthalmia? Suppose I have got a severe penetrating injury in this eye, yes, which is called the exciting eye, to prevent sympathetic ophthalmia in my other non-injured eye, which is called as the sympathizing eye. So to prevent it in this, I need to remove this eye. Yes, enucleate this eye within 2 weeks of injury. 2 weeks is my golden period. And again, I do not enucleate every traumatized eye, even if it is severely traumatized, but still I do have some vision left, then I will not remove it. Okay, so there has to be a documented thing, no visual potential, and a proper consent should be taken from the patient. Should not remove a seeing eye. Okay, so there was a previous year question, I think it's like 5-6 years ago, there was a question on this. So there was an option, what would you do? So normally nowadays, when you have a decent vision, we attempt at primary closure. Primary closure after excising all the exposed uveal tissue. All the uveal tissue, you thoroughly remove, cauterize the area, everything, and attempt a direct closure. That is the first option these days. Okay, but if you have a non-seeing eye, then probably go for enucleation, and your period is within 2 weeks. 2 weeks you have to do the enucleation of the exciting eye. Yes, so that finishes UVEA quiz. And what next? Do you have any questions or doubts in UVEA? Know the topic for tomorrow. In the meantime, let me just look up what is the topic for tomorrow. All right, tomorrow is an interesting topic, retina and vitreous. And all my dear bache, happy Children's Day to all of you. Sorry, I completely missed it. Although I wished you the morning, those of you who texted me, I just forgot them. All right, any questions from UVEA, guys? So tomorrow's quiz is on retina and vitreous, and some of you are wondering where this quiz is happening. The quiz is happening on my Telegram academic group. It's a purely academic group. So the quiz happens there at 6 p.m. sharp, and we do the discussion here at 9. All right. Okay. Any other questions? Any doubts in vitreous? Any doubts? Okay, so again, Fuchs heterochromic iridocyclitis is a non-granulomatous type of anterior uveitis. Okay, so that is why those stellate KPs, or also called as filamentary KPs, are granular, fine and granular in nature. Yes. And Behçet's is again non-granulomatous, but it is capable of causing a pan-uveitis. Okay, non-granulomatous pan-uveitis. Okay, any other questions? Rekha, do you have any questions? Kaushik? Okay, so go and revise retina and vitreous. Also probably revise UVEA for today. And for tomorrow's session, it would be retina and vitreous. So retina is a big topic, vitreous is a small topic. So expect one question or two questions at the most from vitreous. So I will take leave from you, or do you have any questions? Oh, maybe it's TGIF and everybody is out enjoying your Friday. All right, guys. So if you have any questions, you leave your questions down in the comment section. And today, yes, I've also put a video on my Instagram handle, EyeMentor Dr.Rajarathna. So just see the image. The image is very, very high yielding image, and comment on what is the diagnosis there. Okay, so I've labeled the finding for you. So the image is a learning point, and there is a question for you there, which is a diagnosis. So go look at it, take a look at it, and I hope it will be useful for you. All right, bye, bachcho. Good night.